A 78-year-old man went to his doctor for a routine checkup. Healthy, active, playing golf twice a week. No symptoms, no complaints. His doctor ordered a PSA test for prostate cancer standard protocol for men his age. The result came back slightly elevated, not dramatically high, just a bit above normal. His doctor said, "We should do a biopsy to be safe." That biopsy caused a severe infection. The man spent a week in the hospital on the fourth antibiotics. At 78 years old, an infection like that can turn into sepsis and kill you. The biopsy found cancer. Slow-growing early stage. His urologist recommended immediate surgery. But here's what nobody clearly explained. That cancer would take 15 to 20 years to cause any problems. His realistic life expectancy based on his age and overall health about 8 to 10 years. If he'd followed standard medical advice and had the surgery, he would have spent his final years dealing with permanent incontinence, wearing diapers, unable to control his bladder, all to treat a disease that would never have hurt him. This happens more often than you think. After age 70, certain medical tests that used to protect your health can actually harm you. The tests themselves might seem harmless, but they trigger cascades of biopsies, surgeries, and treatments that reduce your quality of life without adding a single day to it. Yet doctors keep ordering these tests. Why? Because it's protocol. Because the medical system is designed around younger, healthier patients. Because the healthcare system rewards more testing, not better outcomes. A landmark study published in JAMA found that 91% of doctors never honestly discuss the risks versus benefits of these tests with their elderly patients. They just order them, you sign the form, and the cascade begins. So today, I'm going to walk you through 5 medical tests that are routinely ordered for people over 70, but that you have every right to question, and in many cases refuse. I'm Sarah Chen. For over 20 years, I've been helping seniors navigate healthcare decisions. And this conversation, most doctors won't have it with you, but I will. This isn't about avoiding all medical care. It's about making informed decisions that prioritize your quality of life. Because after 70 more testing doesn't always mean better health. Sometimes it means the opposite. If you find this information valuable, please hit the like button and subscribe below. This kind of honest conversation about senior healthcare isn't common, and your support helps me continue making these videos. Let's begin. The first test to question is PSA screening for prostate cancer after age 75. The U.S. Preventive Services Task Force explicitly recommends against PSA screening for men over 70. Not maybe consider it. They say don't do it. The harms outweigh any potential benefits. Let me tell you about Robert Martinez, the 78-year-old from the opening. He was healthy, active, playing golf twice a week. His doctor ordered a routine PSA test. The number was slightly elevated, so a biopsy was recommended. That biopsy involves inserting 10 to 12 needles into the prostate through the rectum. For Robert, it caused a severe infection requiring a week in the hospital. At 78, that kind of infection can turn into sepsis and be fatal. The biopsy found cancer, slow growing. Gleason score 6. His urologist pushed for immediate surgery. But here's what wasn't clearly explained. That cancer would take 15 to 20 years to cause any problems. Robert's realistic life expectancy, about 8 to 10 years based on his overall health. If he'd had the surgery, he would have faced permanent incontinence, wearing diapers for the rest of his life, and erectile dysfunction, all to treat a cancer that would never have harmed him during his remaining lifespan. Robert chose active surveillance. 5 years later, he's 83, still playing golf, living fully. The cancer hasn't progressed. Had he followed the original recommendation, he would have spent these years suffering from complications for absolutely no benefit. A landmark study published in JAMA followed 76,000 men and found that PSA screening in men over 70 provided zero mortality benefit. Zero. But it caused significant harm through overdiagnosis and overt treatment. The complications. Biopsies cause infections in 2 to 3% of elderly men, potentially life-threatening at that age. Surgery causes permanent incontinence in 20 to 30% of men over 70 and erectile dysfunction in 40 to 60%, all for no survival benefit. Here's another fact. Autopsy studies show about 50% of men over 70 have prostate cancer. But most never cause problems. You die with them, not from them. PSA screening finds these harmless cancers, and doctors treat them, causing guaranteed harm. If you have symptoms, difficulty urinating, blood in urine, bone pain testing makes sense. But routine screening with no symptoms, the evidence is clear. Skip it. Questions to ask your doctor. What's my realistic life expectancy based on my overall health? Am I more likely to die with prostate cancer or from it? What are the specific risks of the biopsy? What does the evidence show for men my age? If your doctor says it's just protocol without answering these questions, that's a red flag. The second test to question is routine colonoscopy after 75. Colonoscopy is an excellent screening tool for colon cancer in younger adults. But after 75, especially if you've had normal colonoscopies before, the risks often outweigh the benefits. The American College of Physicians recommends against routine screening in adults over 75 with average risk who have had previous negative screenings. This is an official guideline based on evidence. Here's why. Colonoscopy in elderly patients carries significantly higher risks. The anesthesia alone causes complications, confusion, respiratory problems, and falls after the procedure. For someone over 75, these aren't rare side effects. Then there's the procedure itself. The risk of perforation, a hole torn in the colon, is 3 to 4 times higher in patients over 75. If that happens, it requires emergency surgery with a 10 to 15% mortality risk. You go in for screening and end up in the ICU. Bleeding is another major risk, especially if you're taking blood thinners like many seniors are. But here's the bigger question. What are you actually gaining? If you're 75 with previous normal colonoscopies, the likelihood of developing colon cancer that will affect your remaining lifespan is extremely low. Colon cancer takes 10 to 15 years to develop from a polyp into a dangerous cancer. A JAMA internal medicine study found that colonoscopy complications in patients over 75 led to hospitalizations in 5 to 8% of cases. If you have symptoms, blood and stool, unexplained weight loss, then colonoscopy makes sense. But routine screening with no symptoms and previous normal results, the risks outweigh benefits. Safer alternatives exist. Stool tests like FIT or Cologuard can screen without the procedure risks. Questions to ask. Given my previous normal colonoscopies, what's my actual risk? What are the complication risks at my age? Are there less invasive alternatives? Test number 3, Gunda test number 3, routine mammography screening after age 75. The third test to question is routine mammography screening after 75. Similar to prostate cancer screening, breast cancer screening, in very elderly women often leads to overdiagnosis and overt treatment of cancers that would never cause problems during their remaining lifespan. A study in JAMA Internal Medicine examined mammography in women over 75. They found that while mammogs detected many cancers, treating those cancers didn't improve survival. Instead, it led to surgeries, radiation, and chemotherapy that reduced quality of life without extending it. Let me tell you about Margaret, an 81-year-old woman with no symptoms. A routine mammogram found a tiny, slow-growing cancer. Her oncologist recommended surgery followed by 6 weeks of radiation. Margaret had diabetes, mild heart disease, and early kidney problems. Her realistic life expectancy was 6 to 8 years. The cancer they found would take 12 to 15 years to cause any symptoms. If she'd undergone treatment, she would have spent months recovering from surgery and radiation. The radiation would have caused fatigue, skin burns, and possibly worsened her heart condition. For what? To treat a cancer that would never harm her, she chose active surveillance. 2 years later, she's 83, living fully, and the cancer hasn't progressed. But here's what happens to most women in Margaret's situation. They hear you have cancer and panic. They agree to surgery, radiation, even chemotherapy. Their quality of life plummets, and it doesn't add a single day to their lifespan. The data shows that for every 1,000 women over 75 screened, about 5 to 10 are diagnosed with breast cancer. Of those, only 1 to 2 actually benefit from treatment. The rest undergo treatment that harms them without helping. Breast cancer treatments in women over 75 cause significant complications. Surgery complications increase with age. Radiation can worsen heart conditions. Chemotherapy causes cognitive decline and falls. If you have symptoms, a lump you can feel, nipple discharge, skin changes, then testing makes sense. But routine screening with no symptoms, an average risk, the evidence says it causes more harm than good. Questions to ask. What's my realistic life expectancy considering my overall health? Would treating a slow-growing cancer extend my life or just reduce my quality of life? What are the treatment complication risks at my age? The fourth test to question is aggressive diabetes screening with overly strict blood sugar targets in elderly patients. Diabetes management is important, but extremely tight glucose control in frail elderly patients causes more harm than benefit through dangerous hypoglycemia, low blood sugar. For decades, the medical standard has been to keep hemoglobin A1C below 7.0. That target works for younger adults, but for someone over 75, especially if you're frail or have other health conditions, that target can be deadly. Multiple studies have shown that aggressive glucose lowering in elderly patients increases mortality rather than decreasing it. You heard that right. Trying too hard to lower blood sugar can actually kill you. Here's why. When doctors push for very tight control, they prescribe higher doses of diabetes medications. Those medications can drop your blood sugar dangerously low. For someone over 75, hypoglycemia causes confusion, dizziness, and falls. A fall often means a broken hip, which has a 20 to 30% mortality rate within 1 year. Severe hypoglycemia can also cause heart attacks, strokes, and cognitive decline. I met a 79-year-old woman named Dorothy. Her doctor kept increasing her medications to get her a C below 7.0. She started having dizzy spells and fell twice in 3 months, fracturing her wrist the second time. Her A1C was 6.8. Her doctor was pleased, but Dorothy was suffering from frequent, low blood sugar episodes. Her quality of life had collapsed. We reduced her medications. Her A1C went up to 8.0, but the dizzy spells stopped. No more falls. She could live independently again. The American Diabetes Association now recommends relaxed glucose targets for elderly patients with limited life expectancy. An A1C of 7.5 to 8.5 is appropriate for many seniors, yet doctors still push for lower numbers. Here's the reality. For someone over 75 with limited life expectancy, the theoretical long-term benefits of tight control don't matter. Those complications take 10 to 15 years to develop, but the immediate risks of hypoglycemia are real and dangerous right now. Questions to ask. Given my age, what glucose targets are appropriate for me specifically? What are the risks of hypoglycemia with my current medications? Would a more relaxed target be safer? Chwabajimak. Number 5, Ganda test. Number 5, routine CT scans and PET scans for cancer screening. The fifth and final test to question is routine CT or PET scans ordered just to check for cancer. Unless you have specific symptoms or diagnosed cancer, these scans are wasteful at best and harmful at worst. First, the radiation exposure. A single PET scan exposes you to 25 to 30 millisieverts of radiation. The average person receives about 3 millisieverts per year naturally. One PET scan gives you nearly 10 years' worth of radiation in one sitting. Medical experts agree that 100 millisieverts significantly increases cancer risk. 3 PET scans, and you're approaching that threshold. You're getting scanned to look for cancer while increasing your risk of developing it. But the bigger problem is what these scans find. They're incredibly sensitive. They detect everything. And in elderly patients, that means lots of abnormalities that look concerning but are actually harmless. These are called incidental findings. A JAMBA internal medicine study found that incidental findings from imaging led to follow-up biopsies and procedures that caused complications in 23% of cases with zero survival benefit. Here's what happens. The scan finds a small spot on your lung or kidney. Your doctor says, "We need to investigate." More tests follow, maybe a biopsy with risks of bleeding and infection. Then the results come back benign. You've undergone invasive procedures and anxiety for nothing. Or they find something that's technically cancer, but so slow-growing it would never cause problems in your remaining lifetime. But once found, doctors feel obligated to treat it. I saw an 82-year-old man named Frank whose CT scan found a small kidney mass. Further testing confirmed slow-growing kidney cancer. His urologist recommended surgery to remove the kidney, but Frank had heart disease and diabetes. The surgery carried a 15% risk of serious complications. That cancer would take 15 to 20 years to cause symptoms. Frank's life expectancy about 5 to 7 years. Frank chose not to have surgery. 3 years later, he's 85. The cancer hasn't grown. He's living without the complications surgery would have caused. If you have symptoms, unexplained weight loss, persistent pain, targeted imaging makes sense. But routine screening in symptom-free elderly patients, don't do it. Questions to ask. What specific symptom makes this scan necessary? What's the likelihood any finding would extend my life? What's the risk of harmful follow-up procedures? So we've covered 5 tests often unnecessary after age 70, PSA screening, routine colonoscopy, routine mammography, aggressive diabetes control with tight targets, and routine CT or PET scans. These aren't fringe opinions. These are official recommendations from major medical organizations. The evidence is clear, but most doctors don't discuss this with elderly patients. Before agreeing to any test after 70, ask 3 questions. 1. What's my realistic life expectancy based on my overall health? 2. If this test finds something, what would treatment involve and what are the risks? 3. What does the medical evidence show for people my age? If your doctor can't answer these clearly, that's a red flag. You have every right to question medical recommendations. Medical care after 70 should prioritize your quality of life, not checking boxes on protocols designed for younger patients. The goal isn't to live forever. The goal is to live well for as long as you have. Sometimes that means saying no to tests that don't serve that goal. If this was valuable, please like and share this video. Thank you for watching.